Yeah, it's my Facebook DP.
We are live, please.
A very good evening, everyone. Welcome to iFocus Online episode 333, and we are on episode number 8 of oculoplasty module. Today, we have with us our very own Dr. Mritika Sen, who is currently working in Raghunath Nethralaya, but is a product at the site, and proudly so. And she'll be talking to us on evaluation of acquired ptosis. A very brief introduction for Mritika. She did her MBBS from St. GS Medical College and KEM Hospital, Mumbai, and MD from the prestigious RP Center for Ophthalmic Sciences, All India Institute of Medical Sciences in New Delhi, and a long-term clinical fellowship in ophthalmic plastic surgery and ocular oncology from Center for Sight Eye Hospitals, Hyderabad, under the mentorship of Santosh sir, and research fellowship in ocular oncology in Wills Eye Hospital, Philadelphia. She is assistant section editor in IJO of the ophthalmic plastic surgery and ocular oncology section, and a section editor and author of the IJO column Tales of Yore. Currently, she's a consultant in ocular oncology and ophthalmic plastic services at Raghunath Nethralaya, Mumbai. A very, very warm welcome to you, and over to you.
Thank you so much, Shefali, and thank you to the entire team of iFocus and Dr. Honavar for giving me this opportunity to talk on this topic. So I'll just start sharing my screen. And yeah, is this visible? Is this visible? Okay, perfect. Right. So today we'll be talking about the evaluation of acquired ptosis. And before we begin, I just want to say that it covers a lot of topics that may have been covered in the other lectures, but I'll just try to keep it what is relevant to ptosis itself, rather than going into too much of the details. And you guys are most welcome to participate in the discussion as well as the questions that come. Okay. All right. So when we start with the evaluation of ptosis, what are the things that we are looking at? At the end of the examination, we should be able to diagnose the type of ptosis, the degree of severity, associated or complicating factors, including if it's part of a syndrome or something. We should have a basic idea or the plan about how to correct it, and also the expected outcome. All these things are possible just with the examination in the clinic or some of the investigations. All right. So, of course, like any examination, we start with the history. The age of onset will help you determine whether it's a congenital ptosis or an acquired ptosis. The mode of onset can be acute, subacute, or chronic. Now, this is a very a table that shows broadly the types of ptosis which can be acute or chronic. Acute, there are a lot of them, but just to remember simply, most of these are either inflammatory or the neurogenic kind, which present as acute ptosis. On the other hand, chronic is more common with the involutional type. Other than that, some forms of myogenic and inflammatory types can also present with chronic ptosis. Involutional can be either unilateral or bilateral. Similarly, things like myasthenia can be either of the two. Okay. So then we look at the progression. Old photographs are useful to understand the progression. Sometimes the patient might not be sure whether, she may say that she had it from childhood. But if you look at this picture, this child really did not have ptosis to begin with, but it kind of developed when she was, say, 8 or 9 years old, and then it has progressed. So either the ptosis can be progressive, which can be slow, which can have a slow deterioration, which is commonly seen in the aponeurotic variant, or the myogenic types of acquired ptosis. Then you can have sudden onset with improvement over time. That is particularly seen with the neurogenic kind. Okay, now the ptosis can be either non-changing or it can be variable. So quickly, one of you tell me, I think I already asked you this question, what are the types of ptosis that present with variable presentation?
Basically myogenic ptosis.
Okay.
can present with variable like in myasthenia, lambertitan,
Right.
and yeah.
Correct. So you have myasthenia, aberrant regeneration of the third nerve, synkinesis, and even blepharochalasis can have a variable presentation. Okay. Now, the other things to take into account in the history is the family history, that many of them can have a history of ptosis in the family, like in case of BPES or some of the mitochondrial myopathies. Then history of thyroid is important. One, because it can also lead to certain lid changes. Secondly, certain autoimmune conditions can have thyroid associated with it, including myasthenia. Things like bleeding tendencies, use of anticoagulants, cardiac problems are relevant in terms of planning the surgery, but cardiac problems are also associated with certain forms of myogenic ptosis. Then you need to directly ask the patient certain specific questions, like any change where you're suspecting dysphagia, change in voice, history of allergies, and even some medications that can cause ptosis. Some common medications which cause ptosis are, painkillers, which are not so commonly used, morphine, codeine, and all, but topical steroids can also cause. Okay. All right. Now, when we start with the examination, we do the entire ocular examination. Ptosis examination is always done in the undilated state. So you finish off the rest of the anterior segment and whatever you can see before you start with the measurements of ptosis. Fundus, of course, you need to evaluate after you dilate. Okay. Visual acuity and refraction is more relevant for the congenital forms of ptosis and in children. However, there is one variant, which is the congenital type of aponeurotic ptosis, which has the clinical features of an acquired ptosis, but is a congenital type. And some of the children can present with that. So their visual acuity and refraction becomes important. Ptosis patients can have superior visual field defect. So presence of a visual field defect is an indication to treat that ptosis. Okay. All right. So when we look at the patient, any sort of examination begins with the inspection. So you look at the laterality, whether it is unilateral or bilateral, and we just discussed about that. Other than that, you also look at the symmetry of ptosis, whether it is symmetrical or it is asymmetrical. Then you look at the facial asymmetry and dysmorphism, such as is there any frontal bossing, low set ears, or a flat nasal bridge, telecanthus, and things like that. Head posture is again important in the congenital form. It's an indication of the severity of ptosis. Also, head posture, there'll be a chin lift and a head tilt in case of bilateral ptosis, not in case of a unilateral ptosis, not so much, unless it's asymmetrical. But in involutional ptosis or in certain forms of myogenic ptosis, where the ptosis is quite severe, even in these forms, the patients can have a chin lift and a head tilt with the extension of the neck muscles, and a long-standing case can also result in torticollis. Then you look at the frontalis overaction. Again, it's an indication of the severity of ptosis as well as the action of frontalis, the how much it's acting. Then you look at certain things which can cause pseudotosis. So you have to look at whether there's any proptosis, any enophthalmos, any myopia, and you have to look at the ocular movements. Now, all this will become relevant when we discuss specific forms of acquired ptosis. You look at the eyelid skin, especially in patients with involutional ptosis, they will have additional features like dermatochalasis, the skin, there'll be multiple skin folds. You can have associated brow ptosis, or in blepharochalasis patient, the skin is going to be the cigar paper kind and thin. Okay. Sometimes, although it's not so relevant in the Indian population, if it's very thin, you can make out the iris hue through the closed eyelids. Okay. Then on the skin itself, you look for the presence of any lumps and bumps, tumors, or scars that can be indicative of a type of ptosis. Also, tear function tests and corneal sensations, these are important for the post-operative prognosis of the patient. Corneal sensations are also important in the neurogenic type. because any form of treatment of ptosis is going to lead to lag of thalamus, okay, and some amount of exposure. All right. Now, this is just to cover the topic of pseudotosis. There are certain conditions which can mimic the presence of ptosis. So if a patient has enophthalmos, anophthalmos, or a thicycle eye, that the lid just, comes down. There's no true ptosis as such. Patients with thyroid eye disease can have retraction of one of the lids. It can be an asymmetrical form so that one eye appears ptotic. Then conditions like hypotropia and MED or any form of strabismus, you need to check for the ptosis in or do the measurements in the primary gaze. So you, rather primary gaze, I would say, when that eye is fixing. So you need to do the measurements in each of the eyes separately while covering the other eye. That kind of takes care of the pseudotosis component part so that you can measure the actual amount of ptosis that is present. Certain conditions like blepharospasm and dermatochalasis can give a false appearance of ptosis, and certain mechanical causes like chalazion or cellulitis, just to complete the list. Okay. All right. Now, before we begin the examination, I'm just going to briefly tell you that when you do the examination, it has to be in a well-illuminated room. You make the patient sit comfortably with the in an erect posture, and there should be the head should be upright and well supported from the back. All the measurements are taken with the examiner at eye level with the patient's eye, and the light that you shine onto the patient's eye, that can't be too bright because the person will be squeezing his eyes otherwise. So you use a soft and diffuse kind of an illumination and ask the patient to fix at a distance. Give him a target of say 6 by 60. All right. So now I'm just going to quickly run through the different types of things that we look at the measurements in ptosis. Okay. So beginning with the palpebral fissure height, it is the distance. It's always measured in the pupillary axis, and it's measured in the primary gaze, in the up gaze, and the down gaze. And it's the distance between the upper lid and the lower lid. Normally, it's about 9 millimeters, considering the corneal diameter to be 11, because the upper lid covers 1 to 2 millimeter of the cornea. So, one of you has to tell me these. Okay, when do you have the palpebral fissure height decreasing in up gaze? Ruju, do you want to answer that? So the patient is looking up. Yeah, tell me.
In congenital
Ptosis
ptosis,
increasing. Yeah, in congenital ptosis. Dipsy, are you answering?
MED with
Yeah, it can. See, basically, the ptosis worsening in up gaze is generally seen when you have inflammation. Okay, whether it is of the superior rectus or the LPS. Then the ptosis improving in up gaze. What are the conditions where the PFH increases in up gaze? Okay, so there are a couple of conditions. Which one? Sorry.
in a case when there is a lid retraction, like in case of TD.
Correct. Okay, it can happen in Graves' ophthalmopathy. That is good. It can happen in Lambert-Eaton syndrome. Lambert-Eaton is basically a paraneoplastic syndrome. Okay, it's kind of like the opposite of myasthenia, where you have antibodies against the calcium channels, and the function improves with the more that you use it, unlike in myasthenia. Then you can have hyper or hypokalemic periodic paralysis, muscle spasm, or in aberrant regeneration of the third nerve. The ptosis worsening in down gaze, that we already know. That happens in involutional ptosis. And it also happens in the congenital variant of the aponeurotic ptosis. Okay. And the palpebral fissure height increases in down gaze in which condition?
Congenital ptosis.
Congenital.
Correct. What about acquired cases? Which cases of acquired ptosis does the PFH increase in down gaze?
Mm.
Okay, so it does increase in congenital ptosis. That's because the muscle is involved. So it's not relaxing. Okay, neither is it able to contract nor is it able to relax properly. Then trauma, tumor, especially metastasis, the serous kind from the breast, stomach, prostate, etc. Inflammation, like cysticercosis of the LPS or the superior rectus, and aberrant regeneration. Okay, these are the 4 acquired conditions where you can have the ptosis improving in down gaze. Okay. All right. Now the margin reflex distance, that is the MRD1. So the severity of ptosis is always determined based on the margin reflex distance and not on the PFH. That's because the lower lid height also determines the PFH that you get. But MRD1 is not dependent on that. So if you see these 2 pictures, you'll see that this patient has a lot of lid retraction here. So the PFH can be similar in both the eyes, but the ptosis will still be in the right eye if we look at the MRD1. Okay, so MRD1 is the margin reflex distance from the corneal reflex to the upper lid margin in the pupillary axis. Okay, normally it is somewhere between 3.5 to 4 millimeters. MRD2 is the one which is measured from the lower lid, and MRD3 was what was described by Putterman to determine the amount of LPS resection when you have vertical strabismus. So that is measured when the patient is looking up. Okay, it's the margin reflex distance with the patient looking up, and margin limbal distance is again used for the same purpose. It's just measured from the upper lid to the limbus at 6 o'clock with the patient looking up. Okay. All right. So the severity of ptosis based on MRD1, it can be graded as mild, moderate, or severe. If the MRD is 2 to 3 millimeter, then the amount of ptosis is going to be 1 to 2 millimeter. Moderate ptosis is when MRD1 is somewhere between 1 to 2 millimeter, and severe when MRD1 is less than 1 millimeter. But clinically, what you can say, just based on, not so much of an accurate measurement, if the ptosis is on the superior border of the pupil, it is mild. If it's covering half the pupil, it's moderate. And if it's completely covering the pupil, then it's severe. Okay. Margin crease distance, that is measured. You ask the patient to first look down and then slowly look up. The first prominent crease that appears, that is the lid crease or the margin crease distance. Okay. Now this lid crease can either be high. What are the cases where it's high? Subhav, are you there?
Yes, ma'am.
Okay. So tell me quickly, which are the conditions where you can have high lid crease, low-lying lid crease, prominent crease, faint crease, or multiple creases? This is easy.
Okay. High lid crease in cases of where you are expecting the recession of the LPS as an aponeurotic.
Recession.
This like an aponeurotic process.
Yeah.
Yeah.
Okay. Low lid crease. Asian eyelids.
Yeah, Asian eyelids. Yeah.
Where the septum is coming down.
More
The entire anatomy. Yeah.
Yeah.
Okay. Then prominent lid crease. So lid crease is prominent in most of the acquired aponeurotic cases. Congenital ones, it will be faint or absent, except
in Marcus Benjamin. Synkinetic.
Yes, correct. And also the
Neurotic variant.
congenital variant of the aponeurotic process. And it will be multiple in the involutional type. Okay?
Yeah.
All right. So, okay, finally, one more trivia. The lid crease is prominent but the LPS action is poor. What condition?
Aponeurotic variant of ketosis.
Marcus Gunn is
Aponeurotic variant, will the LPS action be poor?
No. Acha, LPS action poor, but prominent crease.
But lid crease is prominent.
and in synkinetic Marcus process.
Correct. Correct. Yeah. So in synkinesis, you'll have a prominent lid crease, but LPS action can be poor. Okay. All right. Now, LPS action, it's the excursion from extreme down gaze to extreme up gaze when you are negating the action of the frontalis. So here you need to be careful that you don't push down the eyebrow, but just keep a thumb here to press the frontalis. Okay. That is graded. What was given by Beard, it can either be good when it is greater than or equal to 8 millimeter, fair between 5 to 7, and 3 to 4 millimeter or anything less than 4 millimeter was poor. Currently, what's followed is 0 to 4 is poor, 5 to 11 is fair, 12 to 15 good, and more than 15 is excellent. Now, 2 millimeter of the lid excursion is contributed by the sympathetic Mueller's muscle and superior rectus. So if the LPS action is 2 millimeter, we don't really consider that. Okay. All right. Tarsal platform show, that was also discussed in the last class. That is taken in the primary gaze, and it is between the lid eyelid margin and the lowermost border of the lid crease or the lid fold that comes. Okay. And the brow fat span, that is going to be from that point to the eyebrow. Okay. Vertical lid height, that is measured in down gaze, and that is important for treatment of, for any, what is that cosmetic surgery?
Blepharoplasty.
Right, yeah, blepharoplasty surgery, where you need to leave 18 millimeter of the eyelid when you're doing the measurement. Okay, just to complete the list of the examination findings. Vertical tarsal height, you need to evert the eyelid, and then generally it's easier if you do it on slit lamp. Then you can just adjust the slit lamp measurement and measure the vertical height. That is important for planning Fasanella surgeries, okay, because you need to leave 4 millimeter of the tarsus intact. Lag of thalamus, you should measure, basically ask the patient to gently close the eyes. Lid lag is when you just ask the patient to follow your finger from up gaze to down gaze slowly, and you can see that there is a slight retraction. So the rate at which the eyeball is moving down is not the same as how much the lid is moving down. Okay. Frontalis action is measured by marking a point on the eyebrow, and then you ask the patient to use his frontalis muscle and look up, and then you can just measure the excursion. Herring's is based on the law of equal innervation. So here you're going to lift up the ptotic eyelid up to the level of the superior limbus, and you look at the other eye. Okay, you keep the scale there and you kind of measure the MRD1 of the other eye, whether that's coming down. There are a couple of things that you see here that it can either indicate that there was a lid retraction, which was secondary to the ptosis of this eye. Or it can also show that when you correct the ptosis of this eye, there can be manifest ptosis of a seemingly normal eye. So that's important for the preoperative counseling of the patient. And synkinesis, Ruju already gave the definition last time, so I'm not going into synkinesis here. Okay. So that has these are the things that you measure in every case of ptosis, irrespective of whatever you're suspecting. Okay. Bell's phenomenon, you need to lift up the eyelid, both of them together, up to the level of the superior limbus, and ask the patient to gently close his or her eye. You don't push and pull the patient, just everything is done gently. And then you look at the movement of the cornea, where normally it goes up and out. Reverse is when it goes down. Inverse is up and in, and perverse is when it keeps on changing. So it can be either good, fair, or poor, depending on how much of the cornea is covered or rather exposed. Okay, that's important in for the post-operative prognosis again. Phenylephrine test, you do it using 2.5% of phenylephrine. This is the test that you do in the end because it will cause pupillary dilatation. So after you have finished with all the other measurements, you do this test. Here you're going to lift up the eyelid and put the drop in the upper cul-de-sac. You ask the patient to look up. Unlike how you normally put the drop in the lower fornix, here you ask the patient to look down and you put it in the upper cul-de-sac, and you repeat the drop 3 times in 5 minutes, and then you basically check it. You can check it after 2 to 5 minutes. Sometimes there can be a delayed response. If you don't find much of a change, you can still repeat the measurement of MRD1 after 10 minutes or 30 minutes. So an improvement of 2 millimeter is considered as a positive phenylephrine test. Okay, now we come to the topic of acquired ptosis. So what are the different types of ptosis it can be acquired? It can be aponeurotic. We generally nowadays don't use the term involutional or senile ptosis, but aponeurotic is preferred because that gives an idea of the basic etiology or the pathology behind the development of ptosis. Then you can have myogenic, neurogenic, mechanical, traumatic, and the inflammatory types. All right. Okay. Tithi, are you online?
Yes, I am.
Okay. So here's a picture. Based on whatever we discussed now, I want you to quickly give me what are the findings here and your diagnosis. Give me the findings first.
The finding is in the left eye, we see appears as a ptotic eye. The border of the upper lid is slightly lower than as compared to the right eye. We will do the evaluation starting from, we observe the lid crease is also higher up in this patient. Then we can start our examination by first making the patient comfortable sitting in a lighted room and start our ptosis evaluation. We'll ask for the history firstly, asking how long the...
Okay, all that is okay. Just tell me the examination.
So we'll start
whatever
with the
you see in this picture. So this is probably a middle-aged to an older individual, just based on this picture.
Yes. And there's also
skin seems okay.
The skin seems fine. There is a bit of a scleral show in the the lower lid is kind of lower as compared to the other eye.
Okay, minor. Yeah.
And we'll proceed with our examination. With our measurements, we'll start with the palpebral fissure height in both the eyes. Then we'll go for the MRDs.
Yeah, that is fine. So basically, when you see anything like this, you talk about that, this is an asymmetrical ptosis, most likely unilateral. We don't know that yet, okay, because we've not looked at herrings, we've not done any of that. But seemingly, the ptosis is more on the left side.
Left side.
Okay. Frontalis, you really can't see the creases that well. So it's probably mild ptosis. And that you can make out based on the MRD, just an average approximation. Okay, it's above the superior border of the pupil, right? So it's a mild form of ptosis. Okay, we can't talk about lid crease here, but we can definitely say that there is a superior sulcus deformity. Okay, because lid crease you don't talk in primary gaze. Okay, other than that, so what do you think is the diagnosis here? What type of ptosis is this? Older individual.
If it's
aponeurotic ptosis.
Okay.
Sorry.
Fine.
It's an aponeurotic kind of, yes.
Ptosis. Okay. Yeah, correct. So aponeurotic ptosis is the most common type of acquired ptosis that we see routinely. Okay. So as Tithi mentioned in all her findings, this can either be unilateral or bilateral. Often it can begin as a unilateral finding and then proceed, depending on the external factor which is causing it. If it is the involutional type, it usually becomes bilateral, although it can be asymmetric. When it's severe, patients can present with, these older individuals, they will give you a history of difficulty in reading or climbing down the stairs because the ptosis worsens in down gaze. Okay. The eyelid crease is displaced upwards. Okay. You can see that again, it's in the primary gaze, but apparently this lid crease is definitely higher. Okay. LPS action is good here because this is an aponeurotic ptosis. The problem lies in the aponeurosis and not in the muscular component. Okay. So the action of LPS is usually greater than 12 or at least fair enough, greater than 10 millimeter. The next three signs are often seen in fair-skinned individuals or if you have extremely thin eyelid skin with disinsertion or dehiscence of the aponeurosis. So you can have a visible iris sign. When you ask the patient to, with the eyes closed, sometimes you can get the iris hue through a closed lid. The Demers sign is when you use a Demers to evert the lid, because it's just the conjunctiva and the skin at the superior border of the tarsus, you can get the metallic sheen of the instrument there. And positive finger test has been described in cases of disinsertion where at the superior border, you can actually feel a kind of a gape. Okay. The lid length increases and phenylephrine test should be done in all cases to assess the integrity of the Mueller's muscle and also to plan the kind of surgery. Okay. And we've already discussed about Herring's and frontalis. Okay, many of these patients are old and they can have certain associated features. Okay, I'll come to that. So what are the causes or external factors which can lead to aponeurotic ptosis? You can have conditions like blepharochalasis, where repeated inflammation can cause dehiscence or disinsertion of the aponeurosis. See the skin here, it is papery and, the cigar paper kind, and you can have a lot of folds in the skin. Okay. Children who often have VKC and have a history of lot of eye rubbing or inflammation, they can develop aponeurotic ptosis. Then history of any intraocular surgery, most commonly glaucoma, cataract. Okay. All of these can cause aponeurotic ptosis. Then things like use of contact lenses. Earlier, it was thought that it's only the rigid contact lenses, but even soft contact lenses for a prolonged period can lead to aponeurotic ptosis. Aging, of course, is the most common cause. Pathologically, if you look at the picture on the left side, this is the posterior lamina of the LPS, okay, aponeurosis. This is where the muscular component is ending. In dehiscence, this kind of becomes elongated and thinned out. In degeneration, there is fatty infiltration, okay, of the aponeurosis, muscle, Mueller's, everything. In disinsertion, this layer disinserts from its tarsal insertion and kind of folds over the orbital septum. Okay, and these are the things that you can see intraoperatively under the microscope. All right, as I mentioned, in certain forms of involutional ptosis, you can have other findings like dermatochalasis, brow ptosis, rounding of the lateral canthus. Again, the rest of the things are, there can be floppy eyelids, lash ptosis in some children with the congenital variant or with VKC, and you also have blepharochalasis. Okay, these are associated findings that you should look for. All right, now, Shefali, do you want to fill in this table?
Okay. So disinsertion, the eyelid crease will be higher up.
Yes.
It has disinsertion.
Ptosis in down gaze.
Yeah, ptosis in down gaze will be more. And LPS action will be moderate.
Okay.
and iris show through the lid.
That's that visible iris sign.
Yeah.
You can get that.
Yeah, it can be present because the LPS has gone, so only the conjunctiva and the.
Yeah, exactly.
Okay, so dehiscence, we can have the lid crease will be seen. It basically might be at the same place or slightly higher up. Ptosis and down gaze again will be more. LPS action will be good, like moderate to good. And iris show through the lid might not be seen. Degeneration, eyelid crease, because it's it's infiltrated with the like it's degenerated, so eyelid crease might be absent, or ptosis in the down gaze will be it might be more. LPS action might be poor, and iris show might be absent in iris show through the lid.
Okay. So I think you were right for most of these things. So clinically, when we look at the patient of an aponeurotic ptosis, you can kind of predict what you'll expect during surgery and therefore plan the surgery accordingly. Disinsertion, as I showed you in the picture, the aponeurosis has disinserted from its tarsal attachment. So lid crease is going to be high, as you said. Ptosis is going to worsen in down gaze, but LPS action is good. Okay. Iris show through the lid will be present. Dehiscence is just that it's thinned out. So the eyelid crease can still be normal or slightly higher up. Ptosis can actually be stable in down gaze. It need not worsen. Okay. LPS action is again good to excellent. And iris show is generally not seen. Okay. Iris show is usually only in the disinsertion type. Degeneration, the crease is in its normal position. Ptosis, there can actually be sometimes lid lag with degeneration. Okay, LPS action is, as you rightly said, moderate to good, and iris show is not present. Okay. All right. So generally, based on this finding, for disinsertion, we plan an aponeurotic reinsertion. For dehiscence, we can plan a plication. And for degeneration, we can plan a resection. Okay, that's broadly. It cannot be based on just these findings. I'm sure that will be covered during the management portion of it. Okay, so Subhav, do you want to take this?
Yes, ma'am.
Okay, talk about this case. What are the differentials and what are your findings? Rather the other way around.
All right.
Findings and differentials.
Okay. So the first photograph on the left-hand side of the screen shows bilateral severe ptosis with use of frontalis muscle, right more than the left, and this is what on 5 case picture, which shows a photograph in the primary gaze with bilateral severe ptosis and use of frontalis action, limited ocular motility in the up gaze, right lateral, left lateral gaze, and down gaze as well. So looks like a case of a myogenic ptosis, or along with ocular motility restriction. Important to rule out CPEO first, and look for pigmented retinopathy changes, look for conduction defects, look for ECG
okay.
changes.
So just based on this examination, you're good. So this is a type of myogenic ptosis, right? As he basically explained everything. So that makes my job easier. So it is a form of myogenic ptosis. Broadly, this can be because of the congenital maldevelopment, or in the acquired type, it can be dystrophic or myopathic changes within the LPS muscle. There can be a problem at the neuromuscular junction. It's actually a separate entity, but often it's spoken about with the myogenic ptosis. But the findings are slightly different. But because of the presence of ophthalmoplegia and ptosis together, it's taken. It's rather grouped under the broad category of myogenic ptosis. And trauma can also lead to myogenic ptosis. Okay. Based on the etiology, it can be the mitochondrial myopathies like CPEO, Kearns-Sayre, or mitochondrial myopathy, the MELAS and the MERRFs. Then you can have oculopharyngeal muscular dystrophy. The rest of them are rare, But just to complete the list, you can have oculopharyngodistal myopathy and myotonic dystrophy. Okay. Now, the characteristics of myogenic ptosis are that it's bilateral, it's usually symmetrical, it can start off asymmetrically, it is progressive, and it is not variable. Here we are discussing purely myogenic and not the neuromuscular junction kind. Okay. Ptosis usually progresses to become severe. The LPS action is moderate to poor, and there will obviously then be frontalis overaction, brow elevation, chin lift, and head tilt. Again, that also depends on the involvement of other muscles. Then you can have generalized ophthalmoparesis or ophthalmoplegia. Okay, like in that case, it was a generalized ophthalmoplegia. Because it is a generalized form, diplopia is not very common. Okay, patient will not present with diplopia. Then poor Bell's phenomenon will be there, and orbicularis weakness can also be there with the involvement of the other striated muscles like orbicularis. Okay. So again, this is another patient with chronic progressive external ophthalmoplegia, and it's following the characteristics that we just discussed. Okay. So it is a severe ptosis. He has the down gaze is often spared in patients with CPO, at least in the initial stages. So as you can see, his downward movements is slightly better. Okay. So CPEO, I'm going to briefly go through the characteristics of each of these. CPEO does present commonly in the clinic, so you should know about this. The patients are young to middle age. It does not begin at birth. Okay, but generally, as the person grows, puberty and beyond, there's no specific sex predilection. Ophthalmoparesis can manifest after several months of ptosis. So ptosis is generally the first feature. Pupils are not affected, and there is no remission or exacerbation. There's a constant progression. Okay. Exposure keratopathy, ocular dryness can be present, and you should look for it. Okay. Because generally you're not really aggressive with the treatment of these patients, rather the surgical treatment of these patients. You have to be highly, highly conservative. Okay. Just to clear the visual axis if you're planning a surgery. Okay. Kearns-Sayre is a variant of CPEO. Here, all these patients have an onset before 20 years of age. And as Subha rightly mentioned, we have to look at the fundus for pigmentary retinopathy. In addition, for the diagnosis, earlier they used to consider that one of these things had to be present, either cardiac conduction defects, CSF protein greater than 100 milligram per deciliter, and cerebellar ataxia. Okay. So this pigmentary retinopathy is more of the salt pepper kind. You don't get the bony spicule kind that you see in retinitis pigmentosa. Okay, and it's often involving the posterior pole to begin with and the periphery. Okay, there can be systemic features as well in KSS as well as CPEO plus conditions. So CPEO plus will have ataxia. Additionally, you can have cardiac conditions, and you can have generalized myopathy. So these involve mainly the proximal muscles like the neck, the shoulder, and the proximal muscles of the limbs. As such, the extremities are not so commonly affected. On the systemic front, you can have a lot of symptoms. The system is getting involved from CNS to auditory. There can be nystagmus, there can be endocrine condition, hypoparathyroidism, diabetes, hyperaldosteronism, as well as gonadal dysfunction, short stature. Okay. But the important one is the cardiac conduction defect that you need to remember. So you have to get a cardiac evaluation done for all these patients and you follow it up, because these can develop after the ocular features develop. Other investigations, so on MRI, CT, as well as ultrasound of the orbit, these patients will have symmetrical thinning of the extraocular muscles. MRI brain can have certain non-specific features. It can be normal, or there can be cortical as well as cerebellar atrophy. and T2 signal in certain areas. Okay, but that's not very specific for CPEO. Then diagnostic muscle biopsy is definitive, and you have the sarcolemmal ragged red fibers. And this is a picture of that. It's basically the enlarged mitochondria which appear like that. The ERG can be abnormal even if RP pigmentary changes are not there. So you can have reduction of the oscillatory potentials, photopic and the photopic B waves, and there can be increased latency of on VEP. Okay. All right. So OPMD, it is rare. It's more common in the French and classically described in the French Canadian, with the highest incidence and prevalence in Quebec. So this presents in the older individuals, older than beyond their 5th decade of life. Okay, the criteria has to be a positive family history, ptosis, and dysphagia by the swallowing test. What was the swallowing test? Normally, a patient should be able to swallow 80 ml of cold water in 8 seconds. If slower than that, then that is there is dysphagia. But generally, these patients present with dysphagia to solids first rather than to liquids. But now, since we know the genetic abnormality, that is more commonly done, and you don't need this criteria to confirm the diagnosis of OPMD. Dysphagia, it is quite debilitating for the patients, and the patient is quite symptomatic with it. This is generally not associated with cardiac abnormalities, so you can differentiate it from CPEO. Ptosis is present in almost 100% of the cases. Dysphagia also, all these develop after ptosis and generally is present in nearly 100% of the cases. Other things include dysarthrophonia, proximal muscle weakness again. Facial weakness can be present somewhere between 20 to 80% of the patients. Ocular motility disorders are seen in almost 70% of the patients, but complete ophthalmoplegia is not common. Pupil is normal. Retinal function is generally normal. MRI is again non-specific for OPMD. All right, coming to myotonic dystrophy, this is an image that I've taken from the internet. It's rare. There are 2 types, but type 1 is the more common type, which is the genetic abnormality lies in the DMPK gene on chromosome 19. Ptosis, as we have mentioned, is characteristic of like the other myogenic ptosis. Myotonia is involuntary delayed relaxation after contraction. So that you check based on a simple test like the hand grip, where after shaking, it becomes difficult for the patient to let go. Or even if you ask the patient to squeeze his eyelid, close his eyelid tightly, it becomes difficult for him to open after forceful closure. Then extraocular muscles, there is varying degrees of ophthalmoparesis. Almost all the patients have cataract, and classically that's described as the Christmas tree variant. Pupil is generally normal, but sometimes because these are, they have insulin insensitivity, they can also develop iris neovascularization. There can be hypotony, ocular hypotony, because of the short depigmented ciliary processes, and pigmentary retinopathy can also be there with abnormal dark adaptation. Okay, but characteristic is the facies. So you have a kind of mask-like facies with hollowing of the cheek, the temporal part. You have frontal balding, and you have these sunken expressionless face. Okay, that is characteristic of myotonic dystrophy, thinned out neck, and the wasting of the shoulder muscles. Okay, other than that, these are some of the systemic features which can be present in patients with myotonic dystrophy. The most severe among these is again the cardiovascular and the respiratory problems. Okay, right. Now we come to neuromuscular ptosis. So myasthenia gravis is the prototype of this condition, and the defect lies at the level of the synapse of the nerve and muscle. Am I like, okay, I am running short of time. Okay, so I'll try to go over this quickly. Okay, you can just tell me when we are, running
Sure,
much
sure.
beyond the time. Okay, so this is an autoimmune condition, and there is variable ptosis. So the age distribution is bimodal. So if it's in the younger population, it presents in the second to third decade, then it's more common in females. However, in patients who are present, older patients, it is more common in males. Ocular myasthenia especially presents in older individuals and is more common in males. Okay, so in myasthenia gravis, the smaller muscles are affected first, and usually this is the order. So you have LPS, then the extraocular muscles of the eye, the other extraocular muscle, orbicularis oculi, proximal limb muscles, particularly the triceps deltoid, and muscles of facial expression, mastication, neck extensors, and then you can have the respiratory muscles as well. So specific questions to ask and also to look for is dysarthria, dysphagia, dysphonia, jaw weakness, okay, opening and closing the jaw, as well as facial weakness. Okay, so one thing to remember in myasthenia is that variability is the only constant. Okay, ptosis is going to be asymmetric, variable, and fatigable. Okay, so here you can see that this patient had a very mild ptosis in the left eye, and again when we measured it after some time or after certain tests that we do, it can improve or even worsen. Okay, so whenever we are looking at a case of myasthenia, apart from everything that we discussed, there are certain specific tests. So this can be in the form of clinical tests, it can be pharmacological, serological, and electrophysiological. So the clinical tests, okay. Shefali, do you want to just quickly describe these, how you perform these tests?
So fatigue test, we can do it two ways. We can either ask the patient to look and in the normal testing conditions that we discussed, basically ask the patient to look up and hold the gaze and test the fatigue.
Go on.
Of the muscle.
Yeah, you go on.
Or we can actually ask the patient to look up and down like 20 times and basically test the do the fatigue test that ways.
Correct. So as you can see in the video, and Shefali explained it very well, you basically ask the patient to maintain a sustained up gaze, and gradually you can see that the MRD1 is changing. So you take the measurement before you begin the test, and then you compare it with post the test. So any of these tests, in any of them, any change by 2 millimeter is considered positive. Okay. All right. Then enhancement of ptosis, which is the manifestation of Hering's law. Okay. Cogan's lid twitch.
So basically, there'll be a twitch of the muscle when the patient is looking from down gaze to upward.
Okay. So how do you, basically what you do in this is, yeah. So you ask the patient to look down for say 10 to 20 seconds and then suddenly look up to the primary gaze. Okay, I'll play this video again. Just look at the right eye of the patient. You'll see a momentary transient lid retraction, which comes and it comes down to its normal position almost immediately. Okay, so there's a twitch, as she said. It's very, very transient, and you need to, quickly measure that. All right, peak sign.
Peak sign, I'm not very sure.
Okay, so that's indicative of the orbicularis weakness. So you ask the patient to tightly squeeze his eyes together, eyes shut, and now the orbicularis is going to fatigue slowly. So what happens is the eyes are going to involuntarily open up, and you can see a part of the sclera through the closed lids, because it's gradually parting. It's as if the sclera is peeking out through between the lids. Okay, you have to look at the extraocular movements. The medial rectus is the earliest one and most common one to be affected, but it's again variable. You can have nystagmoid movements at end gazes. Okay. Generally, the pupil is not involved. However, some cases can have slowly reacting or sluggishly reacting pupil. All right. Okay. Now, can you also get eyelid retraction in myasthenia? Okay. What are the different types of lid retraction in myasthenia? When can you get lid retraction?
But if it's the ptosis is unilateral, according to the Hering's law, there can be a retraction of the other
Right.
lid.
Correct.
Ptosis of the.
What else? Okay. So as you mentioned before, in Cogan's lid twitch, there is a transient retraction. Then you can have a spontaneous lid retraction can happen when you ask the patient, which can last for several seconds when after staring ahead or looking up for several minutes. Okay. Or some of these patients can also have concomitant thyroid dysfunction because both of them are autoimmune. Okay. They can have lid retraction. All right. Now coming to other tests, you have the sleep test and the eyes test. So how do you do the sleep test? Okay. Generally, it is not done in the clinic. You measure, you take the measurements of MRD as well as the extraocular movements, and then you take the patient into a dimly lit or dark room and you ask the patient to shut the eye for about 30 minutes. And then you remeasure it. The ptosis will, all of it will kind of improve. Okay, eyes test. That's something that we normally perform in the clinic and it has one of the highest sensitivity for this. So here you do the measurement, then you apply ice over the closed lids for about 2 minutes. Now the positive effect is going to last for a very short while. So you need to be ready to quickly do the measurements immediately after you take off the ice pack. Okay, so again, improvement of 2 millimeter is considered positive. Now, these tests are also done for myogenic cases, and it's going to be negative in those conditions. Okay. All right. Now, the pharmacological tests, you use anticholinesterase agents because you have antibodies against acetylcholine receptor antibodies at the junction. You kind of increase the concentration of acetylcholine at the neuromuscular junction with these pharmacological agents, edrophonium and neostigmine. So this is a table that is just for your information. Edrophonium is difficult to get, so we generally don't do that. Also, it has a very quick and short duration of action. So you need to take the measurements quickly. It's also associated with greater side effects. So what we generally use is neostigmine. It can be given either intramuscularly or as slow IV. So you generally give it with atropine to counter the muscarinic side effects. Okay, so in adults, you use 1.5 milligram of neostigmine. Generally, it is based on the weight, so that you take about 0.05 milligram per kg. Along with 0.02 milligram per kg of atropine. The effect for intramuscular cases takes a while to start, but in IV, you can start taking the measurements immediately. So you take measurements, repeated measurements at 1 minute, 3 minutes, 5 minutes, 7 minutes, and the effect can last for up to 30 to 45 minutes. So the two things that you look at are the PFH, MRD, and also the ocular movements. It's also better if you can document it photographically. Okay. And these are some of the side effects which can happen. So atropine has to be present nearby. Okay. So after neostigmine, this is the same patient on whom we demonstrated the fatigue and Cogan lid twitch. She did show a dramatic improvement. Okay. Confirming the diagnosis of myasthenia. Okay. Coming to the serological tests, it is an autoimmune condition, so we look for the antibodies. So you have the acetylcholine receptor antibodies that is seen in 80 to 90% of the cases in generalized myasthenia, but about 40 to 70% of the cases of ocular myasthenia. Some of these cases which don't show ACH receptor antibodies can have the anti-muscle specific kinase antibodies. So that's seen in 6% of the myasthenia gravis cases. And these patients generally with those with positive anti-MuSK antibodies have a higher incidence of development of dysphagia, dysarthria, and ophthalmoparesis. You can also have a seronegative myasthenia gravis. That's about 9% of them. Generally, this disease is mild, but they still respond to immunotherapy. Okay. But again, this is not very specific to myasthenia alone, especially the ACH receptor antibodies, and it's also seen in certain other conditions. This is just a list of those conditions. You can have it in Lambert-Eaton, Graves, SLE, basically other autoimmune conditions as well. Okay. So if the test is positive, very good. But if it is negative, it does not rule out myasthenia. Even if it is positive, you need to keep these things in mind. There can be false positives as well. All right, so this is a table that shows the sensitivity and the specificity of each of these tests. ICE test should be performed in all patients, every patient of ptosis who's coming to the clinic. Okay, with the specificity, it has a specific, it's highly specific and sensitive. Sleep test, it has a very good sensitivity and specificity, but you really can't perform. So neostigmine has good sensitivity. Then you can have the electrophysiological tests of these. The single fiber electromyography is highly sensitive. Here you're testing one motor neuron end plate with one single fiber. Okay. And then you do the serological tests. So you go stepwise. You do the clinical ones, pharmacological ones, then advise the serological, and then you do the pharmacological ones. Okay. All right. Okay. Who wants to take this, Shefali? Can I continue or should I wrap up?
I think you can continue. It's 9, but I think we can.
Tell me. So Nilji, should we continue? Do you want to? I just have neurogenic ptosis left technically.
That's okay. We can. Yeah.
Sorry.
Yeah. So it's a left eye ptosis in this child with the oculomotility restriction in the left eye. I think.
Right. So, yeah. So it's a unilateral ptosis. Okay, in a child, as you rightly said. And look at the movements. Is it showing you anything? Third nerve. Third nerve palsy. Okay. So the neurogenic kind of ptosis is the another type of acquired ptosis. So this is basically, it will show the clinical features based on the location of the lesion. Okay. It can be supranuclear. You can have nuclear, fascicular, and peripheral. Okay. Supranuclear will have contralateral ptosis. So wherever the lesion is, the ptosis will be contralateral to it. Okay. Whenever we are talking about neurogenic ptosis, there are some of the common etiological conditions. You'll have vascular, you'll have compressive, you'll have demyelinating, infective, inflammatory, traumatic. Okay. Irrespective of where the lesion is. Now you can figure out based on this, depending on, what are the common conditions which can lead to it at specific locations. Okay. There is also the congenital third nerve palsy. We'll just touch upon the acquired ones more. When we look at the nuclear lesion, the LPS is supplied by a common central caudal nucleus. So generally, you have bilateral ptosis when the nucleus of the oculomotor nerve is involved. Okay. But because it is the fibers of superior rectus, they cross close to it, you can have contralateral superior rectus involvement. Depending on the extent of the nuclear involvement, you can have ophthalmoplegia, other types of ophthalmoplegia, and pupillary involvement, that is involving the ventral portion of the nucleus. Okay. What are the common conditions which can produce nuclear lesion? It's again, similarly, there can be embolic or thrombotic conditions involving the paramedian arterioles and basilar artery, hemorrhage, tumor, inflammation, infections like tuberculoma, Behçet's. Okay, this is just a list. And then you have degenerative conditions, including ALS and the Miller-Fisher syndrome, which can affect the nucleus. Coming to the fascicles, you have these specific syndromes depending on the other structures which are involved. It can be complete or incomplete, and ptosis is ipsilateral to the site of the lesion. Okay, so all right, so you can have the Nothnagel syndrome with cerebellar ataxia. There can be Benedict syndrome with more of extrapyramidal features involving because of the involvement of the red nucleus. You can have Weber's with the involvement of the cerebral peduncle, and contralateral hemiparesis or hemiplegia. And Claude's is going to involve the cerebellar peduncle and the red nucleus with ataxia. Okay. All right. Now, don't look at the table right now. What you need to remember is that the subarachnoid space, the third nerve, is the most common site of isolated oculomotor nerve palsy. That, okay, it is vulnerable to it, especially when it's just about to enter the cavernous sinus. It's attached to the dura there, and the pupillomotor fibers lie at the it's superficial within the nerve. The pupillary nerves are on the outer part of the nerve, so that's why it's more susceptible to any form of external compression. Okay, so you can have a fixed dilated pupil with especially conditions like aneurysm or anything that is leading to a uncal herniation, an expanding kind of a lesion like a hematoma, head trauma, or specific tumors like schwannoma or even basal meningitis. You can have oculomotor nerve palsy with pupillary involvement. That is generally seen again with intracranial aneurysms of the posterior communicating artery, basilar artery. There can be sometimes iatrogenic surgical damage or tumors, including AML, glioma. Okay, this is not, I won't call it an exhaustive list, but you can just remember that you can have either fixed dilated pupil, you can have oculomotor palsy with pupillary involvement, and you can have the pupillary sparing one. So the microvascular ischemic conditions generally spare the pupil because it's not pressing on the peripheral pupillomotor nerves. So this is a table that shows the indications for doing a neuroimaging in a patient with third nerve palsy. So generally in an older individual, if the pupil is spared, he has risk factors like hypertension, diabetes, you can avoid immediate MRI or an MRA. But presence of complete pupillary involvement as well as ophthalmoplegia, partial ophthalmoplegia with pupillary involvement, and pupil sparing but incomplete third nerve palsies, you have to ask for an MRI with or without an MR angiography, because these are conditions which require immediate attention. All right. At the cavernous sinus, that we all know that because it's in close proximity to other structures, there can be paralysis of the oculomotor, trochlear, or the abducens nerve, and the ophthalmic division of the fifth nerve. So you have to look at the corneal sensation. Patients can present with periorbital or supraorbital pain, numbness over the forehead and cheek, and there can also be Horner syndrome because of the proximity with the internal carotid artery plexus. Proptosis can be present, and it can be a bilateral condition because cavernous sinus is intercommunicating. Additional features include eyelid edema and conjunctival chemosis. All right. So these are, again, I'm not going to list them out completely, but these are some of the conditions which can lead to ptosis with the lesion within the cavernous sinus. Okay. All right. Now, when we look at the orbit, you'll have ptosis ophthalmoplegia with vision loss. And there can be divisional involvement. So it can either be the superior division or the inferior division that can be involved while sparing the other. So trauma, tumor, inflammation in the orbit. Okay. Orbital apex syndrome. Again, the third nerve, all these nerves, the ophthalmic division of the trigeminal nerve, and there can be proptosis, but it's less painful than the sphenocavernos syndrome, and optic neuropathy will be there. Okay, so you have to get an orbital imaging done. Okay, you can have a pseudo-orbital apex syndrome, wherein it is actually a neurological lesion which is progressing into the orbital apex. Okay. All right, so these are the different types of recovery that can happen after third nerve palsy. There can be complete recovery, there can be no recovery, or there can be partial recovery with synkinesis or aberrant regeneration. This is just important to know from the management point of view. Generally, in neurogenic cases, you have to wait and allow some time for the spontaneous recovery. At least, I'm talking about just the ptosis component where you're looking at, or the ophthalmoplegia component. Before you take up any surgical correction, give at least 6 months to a year for it to spontaneously improve before you undertake any surgical correction. Again, in this case, the strabismus is treated first, followed by ptosis. Diplopia charting has to be done in all these cases because you need to monitor the improvement or worsening. Okay, and also if you do the ptosis surgery, the diplopia can worsen in these patients. All right. Quickly, Horner syndrome, ocular sympathetic paresis, the triad of ptosis, meiosis, and anhidrosis, depending on what level the sympathetic neurons are involved. If it is the first order neuron from the hypothalamus up till the level of the spinal cord, C8 to T2 levels, it is the ipsilateral body will show anhidrosis, including the face and the the chest, etc. Second order neuron is from the after it passes through the spinal cord, and it is going to go up to the ciliary ganglion. That is when you the sympathetic plexus of nerves in the internal carotid artery. You can have just the ipsilateral face showing anhidrosis, and third order neuron involvement, generally you don't have anhidrosis. Sometimes a small area added to the ipsilateral brow can still show. Okay, so you have children can have acquired Horner syndrome. Here you have to evaluate them for conditions like neuroblastoma. It's basically any underlying neoplasm. Other than that, you can have spinal cord tumors, brachial plexus during birth trauma, or even intrathoracic aneurysms, embryonal cell carcinoma, and RMS. Okay, Horners in children without any surgical history, you have to urgently investigate them for these conditions. All right, so these are the list of common conditions which can affect the first order neuron, the second order neuron from the nerve root to the stellate ganglion, and the superior cervical ganglion, and from there it is going to pass into the internal carotid system of sympathetic plexus. Okay, so you have the central causes with CVAs, multiple sclerosis being most common, preganglionic or second order with malignancies involving the apex of the lung, cervical rib injuries, and lesions of the subclavian artery, lymphadenopathy. Postganglionic or third order conditions include neuron which can affect us, the carotid cavernous fistula.
Dr. Mritika, I think your connection is a little unstable.
Okay. Yeah. Are you able to hear me now?
Unstable. Yeah, now it's fine. I think the last bit we could not catch.
Did you see the causes of the different lesions which can occur at different sites?
That diagram.
That is done, right?
Yeah.
Yeah. So these are the ones that I've highlighted are the most common conditions. Okay, you can have multiple sclerosis in the central, Pancoast tumor in the second order neuron, and third order neuron. Migraine is most common, but you need to look at carotid cavernous fistula, internal carotid artery dissection, or aneurysm, and even herpes zoster. Okay. All right. So in the history, you ask about any history of trauma, you ask about history of surgery, use of any medications, headache, ataxia, diplopia, dysphagia, weakness, numbness, hoarseness of voice. That's in the central Horner's. Headache, diplopia, facial numbness, pain in the third order conditions. So basically, what is the patient going to present to you with? Or rather, what do you look for in, when you're suspecting Horner syndrome in a patient? You'll have mild ptosis. Okay, that's because of the involvement of the Mueller's muscle. So less than 2 millimeter of ptosis, and also the lower lid is affected, the smooth muscle, the Mueller's component in the lower lid. So there can be a reverse ptosis, upside down ptosis with the elevation of the lower lid. Pupil, there'll be meiosis because the sympathetic fibers dilate the pupil. Okay, so there'll be anisocoria, which is going to be worse in the dark. Okay, normally anisocoria up to 0.6 to even 1 millimeter can be physiological. Anything more than that is not. So anisocoria worsening in the darkness is, you suspect Horner's. You can have dilatation lag, and iris heterochromia is seen mainly in congenital cases. Dilatation lag is when you, in the dark, when you look at the pupillary, you shine a bright light to both the pupils, and then you take off the light source. Okay, the involved or the affected pupil will dilate very, very slowly as compared to a normal one in darkness. Okay, all right. Drug tests, quickly, who's going to help me with this? The order and mechanism, and what do we find? I've given you the drugs. Quickly. Shefali?
Not very sure of the drug tests.
Okay, Subhav?
Not sure, ma'am, but apraclonidine.
What drug will you choose to diagnose my Horner's?
None though. We
Okay.
don't do pharmacological tests in the clinic.
So cocaine, I'm just going to give you the theoretical basis for it. You don't really get it, so you can't use it. Okay. Cocaine is going to block the reuptake of norepinephrine that is released at the sympathetic nerve endings at the neuromuscular junction. So you can use anything between 2 to 10%, and you put 2 drops. Peak action is seen somewhere between 40 to 60 minutes. Now what happens? The normal pupil will dilate. Why? Because it's preventing the reuptake. So there has to be some amount of norepinephrine present there for it to have any action. It's not causing any direct stimulation. It's just preventing the reuptake of norepinephrine that's already present in the junction. So a normal pupil will dilate. But Horner's, because there is no norepinephrine at the junction, it's not going to dilate. Okay? So no improvement or worsening of the anisocoria after putting the drop is diagnostic of Horner's in the meiotic eye. Okay? All right. Then then you go on to apraclonidine because cocaine is not available. So for the diagnosis, apraclonidine is what you can actually have access to. So what does apraclonidine do? It's a weak alpha-1 agonist, but a strong alpha-2 agonist. Now, normally in the sphincter pupillae, or rather the dilator pupillae, alpha-1 receptors are less, alpha-2 receptors are more. You use a dose of 0.5 to 1%, and you put 2 drops. A normal pupil initially remains insensitive, but there can be a relative meiosis because of down regulation. Here in a normal pupil, it's going to act on the alpha-2 receptors and cause a down regulation. But in Horner's pupil, the first drop can cause a relative mydriasis because there can be a hypersensitivity, denervation hypersensitivity, because that muscle is not receiving innervation or stimulation from the nerve. The number of receptors available kind of increase. So there is hypersensitivity, and even a small amount of an agonist can cause dilatation. So there is upregulation of the alpha-1 receptors in case of Horner's, and that is going to dilate. But if you do it in that acute state, before the hypersensitivity develops, then you can get a false negative. However, it is sensitive in 80 to 90% of the cases. So dilatation of the meiotic pupil is indicative of Horner's. So this is just to diagnose Horner's, not the level of the lesion. Then you have hydroxyamphetamine that can detect the location of the lesion. So this is going to cause a release of norepinephrine from the postganglionic as well as the preganglionic adrenergic nerve endings. Here again, you use 1% hydroxyamphetamine and you put 2 drops and you check after an hour. If it's a preganglionic lesion, okay, the postganglionic nerve fibers are intact. So hydroxyamphetamine can cause release of norepinephrine at those nerves and cause a dilatation. So if there is dilatation, then if you see dilatation, then it's a preganglionic or central Horner's. But if you have a postganglionic lesion where the postganglionic nerve fibers are affected and there are no norepinephrine stores, it's not going to cause a dilatation. Okay, are you guys following this? All right. And then finally you have phenylephrine that is easily accessible. So you use 1% phenylephrine. That's a direct adrenergic agonist of the pupil. In this case, it's going to be negative in case of preganglionic 1, but again, because of the supersensitivity, it's going to be for the postganglionic 1, the pupil is going to dilate. You use less dose, 1% of phenylephrine. Okay. And finally, you can have traumatic acquired ptosis. Traumatic ptosis can be all these together. You can have aponeurotic, you can have myogenic, or you can have neurogenic depending on where the trauma is. Okay, so like this is causing a third nerve palsy. And you can have mechanical. A lot of lesions of the upper leg can actually present with ptosis, including things like a tumor or a neurofibroma, or this was a lymphoma basically of the eyelid. So do the examination properly. Okay, I'm done. Sorry, I exceeded my time extensively.
Thank you so much, ma'am. It was a very crisp, yet you covered all the aspects of.
For sure.
Yeah. I remember, sir, in his old lectures referring you as his in-house ptosis expert. So now we know the reason for it, and we can't agree more to it. And since you have covered almost everything, we don't have any questions left for you. But one small question, like, is there any grading system for ISPEC test and neostigmine test, like how to grade it, positive, mild, moderate, like?
So there is no mild, moderate, severe response. It is only positive or negative. Positive is any improvement in ptosis by 2 millimeter is definitely positive. You can have a borderline condition where you can have slight improvement by 1 millimeter or so, then you move to the next level of test. Okay. So it is just for the diagnosis, not for grading of the severity.
Okay, that's all, ma'am. Rest all the questions you have already answered. So over to you, Dr. Shefali.
Thank you so much, Dr. Mritika, for that wonderful lecture. Sir rightly mentioned in our chat on the platform, you're a star and we can see why. So much to learn from you. And thank you so much for covering the topic, which and especially the neurological and the acquired the other parts of ptosis, because aponeurosis we see so frequently, so at least that we understand, but the other part, it's even difficult to read and like grasp it in the first reading. So definitely I think everybody's going to see this lecture and be very thorough and clear about it. So thank you so much.
Hope it helps.
See you on the next lecture as a moderator also. And next we meet on August 30th, which will be Management of Congenital Ptosis by Dr. Usha Kim. So thank you so much and have a very good night, everyone.
Thank you. Good night.
Thank you. Good night, ma'am.
Good night, ma'am.